Good afternoon, everybody. Thank you, Dr. Aditya, for inviting me in your course. So, whenever you see postoperatively this kind of picture, mild corneal edema, AC cells flares, with or without hypopyon, poor glow, and the vitreous membranes, and mild grade of vitritis, and it is going off on by applying this topical or systemic steroid. Think about the fungal endophthalmitis. So fungal endophthalmitis is actually caused by the intraocular fungi infection originating either from exogenously from penetrating trauma or by surgeries, or endogenously from the hematogenous spread. It is highly variable in clinical picture. A post-operative fungal endophthalmitis, although it is rare, it can occur due to the Aspergillus or Candida species. It can present as subacute postoperative endophthalmitis or chronic postoperative endophthalmitis, just like other picture, but not that fulminant with or without hypopyon or with. I am coming to the other clinical pictures. So another mode of endophthalmitis, fungal endophthalmitis, is post-traumatic. Although bacteria are the commonest cause, but Aspergillus is the most prevalent fungal cause of post-traumatic endophthalmitis. And the continuous spread of the fungal keratitis, it is the rarest of the fungal endophthalmitis. So endogenous endophthalmitis, another mode of presentation of this fungal endophthalmitis. This infection is secondary to the hematogenous spread from a distant infective source within the body. It actually occurs in 5 to 10% of the all endophthalmitis cases, when actually they are in the bloodstream. It affects the choroid, because choroid is a very vascular structure, crosses the blood-retinal barrier, infect the choroid, then followed by subretinal space and the retina, and present as focal chorioretinitis or focal retinitis. So that is the one of the variety of endogenous endophthalmitis. One of the four types of that is anterior focal, anterior diffuse, posterior focal, posterior diffuse, and the pan uveitis like picture. So the causative organism may be bacteria as well as fungi. Fungi causing the endogenous endophthalmitis principally it is their Candida albicans and Aspergillus, and rarely yeast. So these factors, either immunosuppression or any procedure that increase the risk of blood-borne infection, that cause that infection. So in immunosuppressive diseases like diabetes, HIV infection, all other cancer, renal failure, all are like using a long-term use of the broad spectrum antibiotics, steroids, immunosuppressive drugs. They are risk factors, and the major surgeries, either by the intra-abdominal surgeries or hyperinterventional IV catheter use, or per se systemic immunosuppression is not influencing the development of intraocular candidiasis, because it does not increase the access of candida into the bloodstream. So decreased vision, pain out of proportion, edema, corneal edema, corneal ring infiltrate, or keratitis, anterior chamber inflammation, hypopyon, all these are fungal ball over the iris, and vitritis or frank purulence is the common clinical features for a case of this fungal endophthalmitis. And the mode of diagnosis, like if diagnostic tools are most on the ultrasonography, you have to do it whenever you see there is loss of glow, like the very poor glow, or you can hardly see the fundus. So they are actually non-specific, but sometimes you can see the membranous picture in the inside the vitreous cavity. And the culture of the intraocular fluid is another mode of like diagnosis, either from the anterior chamber or the vitreous tap. You can do the blood culture for a complete workup of the systemic infection. PCR is, you can take the vitreous biopsy. I'll show the video how to take the vitreous biopsy. So basic steps, and you can send it for the laboratory use of like using the KOE staining, as well as the culture, as well as the PCR use of PCR to diagnose the what is the like to detect the fungal DNA if possible. And recently they have measured the levels of intraocular fluid beta D glucan, which is actually described by Chen et al. In 2020 as having the close association with the fungal endophthalmitis and being more sensitive than the culture methods, as it is limited by the inability of to confirm the specific diagnosis. So management depends on the actually it's the fungal and systemic antifungal therapy, either fluconazole or voriconazole for candida, intravitreal therapy for fungal endophthalmitis, either intravitreal amphotericin B or voriconazole. So both are good, equally good, but voriconazole has lower risk of retinal toxicity. This is the drug intravitreal preparation. I'm not going into details, but just amphotericin is covering the candida aspergillus, and voriconazole also aspergillosis, invasive aspergillosis is better than amphotericin B, and for candida it is as effective as amphotericin B. So the advantages of vitrectomy are as of routine bacterial cases, but additionally it can decrease the risk of further retinal detachment. So this is the another thing. But retrospective study, one small retrospective study has been done where 44 eyes with endogenous candida endophthalmitis was actually at early vitrectomy didn't help much to prevent further profound vision loss. So how to take vitreous biopsy? This is the video I'm showing. That is, before starting your vitrectomy, you should take the vitreous culture by cutting the aspiration tube with the 1 ml tuberculin syringe and using visualizing the vitreous membranes with the help of your endoilluminator. Start the cutter with the cutting mode only without making the infusion on, and take the sufficient fluid from the vitreous cavity to send it for the KOH staining, for the culture as well as the PCR reaction, so that you can reach to the proper diagnosis whether it is bacterial or fungal, and that will help in further management. So I'm coming to the one practical cases where post-operative chronic endophthalmitis. Ultimately, patient came and the diagnosis was aspergillosis. So vitreous biopsy showed aspergillus in the vitreous culture. Vitreous biopsy material shows the aspergillus species, and you can see the basic steps to manage the endophthalmitis case. You should remove all the media opacity. That is the most important part. That is, you should remove all kind of media opacities, like from the corneal edema. You should remove the corneal epithelium, followed by anterior chamber membranes. All the membranes should be removed with the help of either this Sinsky or the Dumble cannula. You can see I'm just trying to remove the membranes were very tenacious. So you can always use cutter to remove these membranes, basically to visualize the further now you can see I can visualize the anterior chamber, that posterior chamber lens, and using this cutter I am removing all the pupillary membranes, and finally you can see it is almost clear, but you can see the tip of the cannula. After checking the infusion cannula again, then I'm starting my vitrectomy part. Then after doing initial anterior vitrectomy, you can see the vitreous exudates and the fungal cotton ball exudates overlaying the retina as well as throughout the vitreous cavity. You can see all the membranes. These are the real time. You can see the characteristic membrane of any kind of the fungal endophthalmitis. Wherever you can see the membranes always have it should be there's a good high suspicion of fungal cause. And after removal of all the membranes, you should remove all the fungal balls overlaying the retina, and sometimes it is not it's difficult to do the posterior vitreous detachment, but still you can use the cutter to remove all the IPVT part, and just remaining part of the over the linear disc, you can lift it as such, and using either section of the cutter or using it the proportional reflux mode of the cutter, you can remove all the vitreous cotton balls, and finally inject the intravitreal antibiotics as well as the antifungal drugs. Sometimes what happens when you are injecting both vancomycin and voriconazole, they can form precipitate formation. So these are not hypopyon postoperatively. If you see, you can detect it on the table also. So always keep in mind that the other difference in diagnosis, like non-infectious uveitis and infectious chorioretinitis, like bacterial endophthalmitis, viral endophthalmitis, and toxoplasma chorioretinitis. Also try to rule out the malignancy like intraocular lymphoma and retinoblastoma in children. Always have some mimicking picture with the fungal endophthalmitis. Thank you.
Thank you, Dr. Boral, for your excellent talk. Would you be hesitant in adding steroids when you have the fungal endophthalmitis in the first intravitreal injection encounter that you have? Suppose patient has come post-operatively to you, you suspect fungal endoph. How do you want to give intravitreal antifungals with steroids or without steroids?
No, we are not adding steroid when I have a strong suspicion of fungal endophthalmitis. But later on, if sometimes what happens, that is also reverse kind of situations may happen. And when you do not know whether it's you are suspected with the bacterial endophthalmitis, you have given steroid, and ultimately culture came positive, or KUH stain came positive. So after 1 or 2 days, I am just stopping this in the steroid drops. But when you suspect the fungal endophthalmitis, you should not start this thing. A non-steroid anti-inflammatory drug should be the mobile, or you can use the cyclosporine.
Yeah. And your drug of choice is intravitreal endophthalmitis fungal drug of
Fungal,
antifungal is
fungal. I am just, that is the empirical dose of that is vancomycin, voriconazole, and voriconazole or amphotericin, whichever is available, and cefuroxime, or ceftazidime. Yes.
So mainly it's about voriconazole or amphotericin B between the
Especially
two.
in amikacin in post-traumatic endophthalmitis.
Right.